think this is it. And first of all, I'd like to say welcome this morning. Glad to have all of you here. Actually, afternoon. That's how fast my day's been moving. Before I start, we have a cadre of people here, and I'd like to take just a moment to introduce them. I will put your mind at ease. They are not going to speak for 30 minutes apiece, so you're safe, but they will be available for questions if something comes up that would pertain to their particular area. First, I'd like to introduce Julie George. She's the Executive Director on a Board of Nursing over here, and Megan Williams, who's President of the North Carolina Nurses Association and Family Nurse Practitioner. Dennis Taylor, Acute Care Nurse Practitioner. He's from Charlotte, and he's also Chair of the NCNA Commission on Advanced Practice Nursing. Sarah Hubble is a Family Nurse Practitioner, and she's Chair of the Council of Nurse Practitioners. Leslie Sharp, a family nurse practitioner as well, and leads as a lead provider at the Sylvan Community Health Center in Snow Camp. And Shaquita Peacock, a family nurse practitioner and co-owner of her own practice. And Shannon Keller, who is an aspiring certified nurse midwife, and she'll graduate next month with a master's in midwifery from ECU. So you do have their bios in your press kits, and you can see what they do and are involved with. If you have questions, you know who to direct it to. And before I turn this over to Senator Hise, like any good politician, I'm not going to lose an opportunity to say a few words. And that's primarily the fact that every day we're hearing the problems we have with health care in North Carolina. We've got a crisis here and a crisis there. We don't have access. We don't have full service. We can't take care of everybody. And there's a very unfortunate grain of truth to all of those issues. And we have here in North Carolina, though, the resources between our universities and our companies in RTP, our pharmaceutical companies, anybody connected with the medical industry, where we should not be having those problems. And some of those problems, unfortunately, lay at the feet of legislators because of statutes we have in place that are outdated because of changes in technology, changes in education, the profession across the board. And also just because we put in a lot of restrictions that today don't really help us. And that's one of the purposes of what we're here for with these bills. A lot of times they serve as the beginning to start a conversation. We don't want to rush into a lot of things, but we do want to begin to explore what changes can be made, how quickly they can be made to bring benefits and not problems to citizens of North Carolina. An example of that's the nursing profession. I don't know of a profession right off the bat that has changed so dramatically from the day I met my first nurse. And it's probably been 50 plus, and I'm not going to tell you exactly how many years ago. Because they now have levels of training that are phenomenal. And we need to have legislation in place and processes in place to take advantage of every bit of that ability for the citizens of North Carolina. So I look forward to your questions and support for what we're trying to do. And I'll now let Senator Hise take the stage, and he will be also letting Mr. Conover speak with us today about a study I think you'll find very interesting. Thank you.
Thank you, Representative Avila. Thank you, everyone, for coming to see this today and allowing us to present. As many of you know, I represent rural parts of western North Carolina. I represent many of the mountains in this state that are moving forward. And one of the things we're really seeing in healthcare is a difficulty in getting access to healthcare. I myself, for most services outside the hospital or doctor, it's more than an hour drive to go to Asheville or Johnson City to get any significant services in healthcare, and that's with a local hospital. Individuals for OBGYN services and others, if we're fortunate enough to have someone one day a week that can come to the community and provide those services, otherwise it's moving to the metropolitan areas that separate us. You look at where we've come in that area and you compare it to what else we're seeing with an aging population that has more demands on health care each year, and our medical providers are retiring at a rate faster than we are graduating individuals into the medical professions. All that is leading to major problems coming in our healthcare system. When you stack on top of that all the major changes the Affordable Care Act and even our own legislation has placed upon the system over the last 3 to 4 years, we need to make major changes in healthcare. That is what we are trying to do here with both Senate Bill 695 and 507 and 807, House Bill 807. We're trying to create access. We are trying to finally recognize for legislative purposes how much the role of nurses and particularly advanced practice nurses have changed in the state. I myself go see a nurse practitioner for everything that is done on a primary care level. I have a primary care physician. But when I want to adjust medications or I want to talk about things they're doing, we've never really fully recognized that in our state. Well, we keep it under, and so that's what we're trying to change here with this bill. I will say that the hardest thing in the healthcare industry right now, as much as it's been shaken on its head in the last few years, is change. The industries don't want to change. They want to operate in the same structure and manners that we've seen for decades. And there are people that oppose this bill for that very reason. They want to keep their control and they want to keep their direction on health care, even though they're creating systems that are failing communities. We're looking to remove some of those regulatory burdens with highly trained medical jobs that will serve in our rural communities that are coming out, but it will also save millions of dollars. We have in your press kit, many of you will see some of the direct benefits of these bills will generate for our state. A recent study conducted by Christopher Conover from Duke University, Center for Health Policy and Inequalities, their research highlights the benefits of addressing the current regulatory burden placed upon APRNs in our state, and by removing many of these burdens, we show what we can improve access and improve the quality of care. We will bring up, before we go into some questions and others, I want to take the opportunity to bring Mr. Conover up and ask if he'd hit a few of the key points from the study and the information you have, and then we'll go to questions. So appreciate it very much. Thank you.
So let me start by noting that throughout this report, we've deliberately selected conservative analytic assumptions, and that gives me high confidence that all of our lower bound estimates of the impact of removing restrictions on the practice of nurses represent a true floor on what's going to happen relative to what's actually going to happen. So whenever I use a lower bound figure, I feel very comfortable in saying that less restrictive regulation of advanced practice nurses is going to have an impact of at least that magnitude. So let me just focus on, you've got the handout on some of the facts and figures from the study. I want to highlight the impacts on health spending and on the physician shortage. The various studies have indicated that expanded use of advanced practice nurses by removing under less restrictive regulation would produce annual health system savings of anywhere from 0.63% to 6.2%. That's a big range, obviously. In North Carolina, annual spending we estimate was $69 billion in 2012. So these numbers translate into annual savings of anywhere from $443 million to $4.3 billion. That's a lot of money. That amounts to $44 to $437 per North Carolinian. Now, the lower figure is based on the results of a RAND Corporation study that was done for the state of Massachusetts. It only focused on nurse practitioners and physician assistants. The higher figure is from a Texas study that looked at all 4 categories of APRNs that we looked at in our study. Now, I haven't done a fine-grained analysis of the difference in regulatory practices here compared to Massachusetts and Texas, But my sense is that we're closer to Texas in terms of our restrictions on regulation than we are to Massachusetts. So I can't say with precision how much the annual savings is going to be, but I think it's going to be closer to the $4.3 billion figure than the $433 million figure. In terms of the impact on the physician shortage, a number of studies by very reputable organizations, including the North Carolina Institute of Medicine and the RAND Corporation, have projected potential shortages of physicians in North Carolina by the year 2020, and as you've already heard, that already exists to some extent today. We did not try and replicate or update these estimates. We took them as they were, except that we did do the adjustments as necessary to take into account the expected impacts of the Affordable Care Act. We expect that if the ACA or something similar to it is fully implemented, the demand for care in North Carolina by 2020 will go up by 3.1% if we do not expand Medicaid. It will go up by 5.7% if we do expand Medicaid. I'm not a political prognosticator, so I don't know which will happen. I can just give you the range of what will happen. We project that less restrictive regulation of APRNs would result in a net increase of 1,744 full-time equivalent APRNs relative to the 2012 supply. Now, we recognize that principally due to differences in the number of hours of work per year between APRNs and doctors, one advanced practice nurse does not completely substitute for a doctor in terms of the number of patients they can treat every year. So using appropriate substitution ratios from the literature, we calculated how much of the projected shortage of physicians by the year 2020 might be alleviated through greater use of APRNs. And you can see the results in the chart here. The lower bound numbers represent the worst case scenario in terms of the doctor shortage. That is, if the doctor shortage is very large, then any increase in the supply of APRNs is going to only have a modest impact on the size of that shortage. Conversely, if the shortage of doctors is pretty low, then any given increase in APRNs is going to have a relatively greater impact. So we estimate that the combined increases for nurse practitioners and clinical nurse specialists would reduce the projected shortage of primary care physicians exclusive of OBGYNs by at least 92%. The expected increase in nurse midwives alone would reduce the expected shortage of OBGYNs by 17%. However, it's important to understand that nurse practitioners and clinical nurse specialists also can reduce the demand for OBGYN, since it's, depending on what their scope of specialization is. So hypothetically, it's feasible for the expanded use of APRNs to completely eradicate the shortage of OBGYNs, in which case that would still reduce the shortage of non-OBGYN primary care docs by 83%. The expected increase in CRNAs would eliminate at least 85% of the expected shortage of anesthesiologists, and possibly could eliminate that shortage entirely. Thus, overall, right-sizing the regulation of advanced practice nurses has the potential to decrease the shortage of all non-federal physicians by at least 41% and possibly eliminate that shortage entirely. In either case, that would be great news for North Carolina. I'm happy to take questions.
Do we have any questions from the audience?
Just a point of clarification, I'm Jason DeBruin with Triangle Business Journal. Why is the effect on OBGYNs so much smaller than the other ones?
Only because in that particular bar, we're only focusing on the nurse midwives and their impact. And that's the reason I put the caveat in. If you take into account what's the increase in supply of nurse practitioners and clinical nurse specialists, that also could, it would change that bar entirely. It would say we eliminate that shortage of OBGYNs. So it's only because we're focusing on one narrow slice of APRNs.
Are there any other questions or comments? Well, this is an easy one. We just covered everything. Okay, if there are no questions, I won't keep anybody waiting. It kind of looked like you're poised for.
So I thought you were asking specifically for Dr. Conover.
Oh, no, I'm opening up the floor for everybody.
Right.
I know one of the arguments in favor of deregulating or in favor of the bill is, of course, that we would get more healthcare professionals in rural areas. Why would nurses be more likely to go into rural areas than doctors are?
Well, I don't know the reason why, but the empirical evidence suggests that they do.
And I will say that when you look at admissions into schools in North Carolina and individuals coming out into health practice, the highest rates right now of individuals practicing in rural areas throughout all healthcare are for nurses who come from rural areas and are trained in the community college system. East Carolina and others can do some things with their practice, but most doctors we train to say at Carolina, we're having about 18-19% that even stay within the state, and that's exclusive of our urban and rural areas that come back here. In our nurse practices, we're having as much as 80% stay within state. That's what coming in, and for our rural areas, it's the most success areas we have in getting practice there. That has been the historical trend, and expanding that cope would do nothing but continue that trend moving forward and give individuals opportunities to move up in their practice.
You mentioned the doctor shortage, but isn't there also a nursing shortage? Aren't the numbers declining also with nursing school graduates?
Hi, I'll step to that.
Could you step up here, identify yourself, please?
Thank you. I'm Julie George, Executive Director for the North Carolina Board of Nursing. And actually, there's a lot of debate over whether there is or is not a nursing shortage at a national level. There's been a lot of work by Dr. Peter Beerhouse out of Vanderbilt about that. And the more recent numbers actually show that, and this is true for North Carolina, there's a slight increase in the enrollment and the graduation and entering into practice of registered nurses. It's a bit of a downward trend for the licensed practical nurses, just as jobs and the job market has changed a bit, but there's a huge upward trend in advanced practice registered nurses. So that's true in North Carolina, and I would say throughout the country. They've really, they're growing in numbers.
So if we're shifting some of the duty and the care and the treatment into the nursing specialties, does that leave a void there with traditional services, traditional job functions for nurses?
Not from
Are you stretching?
Right, no, not from my perspective, because this legislation does nothing to change anything about the scope of practice for either the LPN, the RN, or these advanced practice registered nurses. So you still have people practicing at their level providing those services. I think the benefit of the bill is that for those advanced practice nurses, it would reduce barriers and even be more desirable, if you would, for those practitioners to come to North Carolina. At the present time, if they are practicing autonomously in another state, there's a real concern about their willingness to even see us as a viable or attractive place to work. So, as I said to someone, it was 1981, President Ronald Reagan was in office when we amended the Nursing Practice Act the last time with any major change, and people were listening to 8-track tapes in their car. So this is really just moving us into the 21st century, and I think it's time for that, and I really applaud the bill sponsors for being willing to do this. Thank you.
Yeah, could I add just one point? The practice environment is actually critical. We shouldn't think of like a fixed supply of nurses. The supply of nurses is going to respond to what the incentives are in the system in terms of regulation. So in order to do our estimates predicting how many more APRNs there would be if you loosen those restrictions, we looked at states that did have looser restrictions, and they experienced 24% higher growth or more APRNs after a 7-year period compared to states like North Carolina that had more restrictive practices. So that's the whole point. If you can remove those restrictions, now you're going to attract more APRNs. You're going to even send people within North Carolina to go into that kind of training, or you're going to attract other people from outside of North Carolina.
And to follow up with that, from a Western North Carolina perspective, I've seen for the nursing in the last few years, you've had Western Carolina open a nursing school now in Asheville. You've had Appalachian State University waiting on accreditation now to begin offering their nurse program. Mars Hill University has also begun offering their nursing program, in addition to expansion at all our community colleges. I work at community college. Community college is known for open admission, except when it comes to the nursing programs. That's where we are turning down students every year to get into our nursing programs, and we are prepared to respond in the state. We need more faculty and others, and we can put more nurses out in a quick time period and turning around, both on the advanced side, which is what the universities are responding to, and at the RN level, which both the universities and the community colleges can respond to. You've seen no changes in our medical schools and graduations over the same times.
So are you expecting any financial impacts with any legislative changes?
I don't think at this point that we will have budgetary impacts within the biennium for the changes that are coming in. But as you'll see in the study, I expect long term, when we talk about more than $60 billion in spending in North Carolina in healthcare, when you have 20% of our state population on Medicaid, 6% of your state population on the state health plan, if you're reducing the cost of health in this state, there is forthcoming a great impact on the state budget.
I'd like to make a comment along this line too, because I don't see nurses supplanting doctors or replacing doctors. With this growth in the advanced practice nurses and other specialty nurses, I see them expanding the availability of services because of the doctor shortage and just the fact that there may be things that they, at a higher level, they could be concentrating on, while we have people at the advanced practice level and others taking care of health issues and being able to serve more people, and completely eliminating the big question we've got here in the state, and that is primarily access, of just literally having enough people to supply the needs of our citizens. Yes?
I'm going to ask you just to opine a little bit. We heard that the regulations haven't been changed since the Reagan administration. Many other states have changed them. Why have we not?
It's an interesting dynamic there. There's a lot of stuff going on every session. And there have been changes to the Act as we've added things to it. But in looking at the entire scope of nursing in relationship to the healthcare profession and exactly how we've set it up, that has not been looked at in that period of time. But I think it's partly driven as much by the changes in the educational level. You've got nurses now with masters and PhDs, and you're talking about a system that hadn't been, it's 30, how old is my son? 34 years since they looked at this. So I think it's way past time, because things have changed dramatically in that 30-year period.
Sure.
Good. Has the medical society weighed in at all? Or do they see any conflicts? Or are they supportive of this?
Well, I may be more of a bold statement from my opinion to that response than hers, is that when you have a monopoly on a system, you tend to fight things that make changes to that monopoly when you're moving forward and go forward. We've had a lot of good conversations with the medical society and others in this. They've been very aware of the development and put forward to this, but we've had even better conversations with the hospitals and practices. I see it as kind of a duplicitous role, because advanced practice nurses work with doctors every day, and whatever setting that they're in, their role is established within that, and it's been an incredible relationship. Sometimes when you're representing the legislative theory of this whole thing and what should be, they take a much more hardline stand for the same individuals that will hand over a lot of their work and practice to them every day. So, but directly, I don't know that I would suspect that the medical society will ultimately be in support of this.
We've obviously conversed about House Bill 200 as well. In that case, the changes seem to be, I know I've called them baby steps, they do seem to be a little bit smaller. Is it fair, in your perspective, to characterize this bill as being one that would, maybe not quite an overhaul, but at least change the regulations to a larger degree, especially compared to, say, House Bill 200?
I think in terms of effect, that bigger steps with 200 are much more impactful, and I believe that what they're laying out with the direction that they're headed here, that we will see we can unwind without a lot of really upsetting effects in the procedure. A lot of it's just simply going to be changing people's way of thinking about how the supervision and how the oversight should be handled. In particular, what I've looked at is one of the key things that we need to examine and possibly change.
That makes sense.
Any other questions for anybody? If not, as they say in committee, we're adjourned.
Thank you very much.